Thank you, David. I really appreciate it. I was just hoping he would be super brief and say, Ross from Concord, Mass. So we're going to talk over the next 50 minutes or so on a grand tour of what I think is a complicated story. And it's really and very much a bit of a knot. And what I'm going to try to help you do, because we haven't done it all yet, is tease apart some of that knot. Not what everybody believes is true, and not what everybody believes is accurate. These are my disclosures. The most important ones are related to my federal funding and my prior work as an INC and UNC for the National Football League, the NHL, and the NHLPA. And this study that I will describe in much part is in part funded by the National Football League Players Association. I have some NFL videos here. I'm going to ask the team to turn away from those. I have them with permission of Tom Mayer for us to use as educational purposes only. Okay? And some of the work is unpublished and exciting. They're not quite yet out. They've been reviewed, so I'm going to ask people not to take pictures of that. So my overt thanks goes to these gentlemen. They are remarkable. They are our advisory board. They are former players, NFL players. I would argue to you that they are bigger, sure. They are stronger, sure. Their visual spatial function is better than the rest of us. They are selected upon selected. They are the 1% of the 1%. And so that's in part why they are very interesting. A, we want to help their health most compellingly, but B, what can we learn for the rest of us if someone like that is having problems? There are going to be some caveats. Exercise is good. This is a very nuanced stories. Pros are not the same as everybody else. They have been selected multiple times, and I'll show you some examples. And we'll have a little bit of data on high school, but not that much. General caveat, brain injury is bad. I learned that over 35 years. But repeated brain injury is probably worse. But that's not the whole story. ESPN and other places have wanted to make that the whole story. It's not the whole story. Extremes have extreme gifts and exposures. Not everyone is sick. I have former patients who are older than me whose biggest problem is their knee hurts and they're selling property in Arizona. And I have people who are a decade or more younger than me who have severe cognitive and heart and other issues, and those things are both real. Joy matters, and I'll talk about that, how we interpret things. And team sports have a benefit, right? And I'll show that in a second. Remember, all extremes have a problem. This is a paper at the top from our colleagues back in Boston who basically worked with the ANOVA people and showed marathon runners may be more likely, especially ultra-marathon runners, to get colon cancer. Right. Surprise. Everything at its extremis may have a price. And don't say that I don't endorse it, or I'm anti-sport or anti-team sport. The gentleman you see there in the white hockey jersey is my son. So we have a bit of a Gordian knot. So let's try to slice through it a little bit. So we're going to answer some questions. Why is football interesting to begin with? How has the game changed? Has it changed? Have they done anything in all of this time? Not everything is bad. Some other sports are affected. There is a link to neurodegenerative disease, but not in everyone. And we'll show when. And there's a link to chronic medical conditions. Why is this interesting? It's interesting not only because of what you see, I think, on your right, which is the television ratings in the United States, the top 100 most watched U.S. programs. Can anybody figure out how many of them are football? The reasoning is is everyone watches a show on Netflix. Everyone watches a show another way, a movie in part. I don't care once I know if someone won or lost. You watch it live. It has crazy revenue associated with it. It's a television business. It is a TV and entertainment business as much as it is a sport. When we think about everything, not everything is a nail. So the old saying is, if I have a hammer, everything is a nail, and that is just not the case. So these lives of these gentlemen are extremely interesting, but their problems and diseases are not just reflected with head injury. My goodness, I've studied that for over 30 years, but it's not the answer. It's part of a very complicated answer. And so what we became very interested in is what causes a maladaptive phenotype? Where are the extremes in comparison? So a part I'll talk to you in about 5 minutes about a part of our study that compares those who are ill and those who are well after equal amounts, almost a human knockout in some ways. So let's start with a different approach, and that is to answer a question: has the game gotten any better over time? And the answer to that is yes. It's better. Didn't say it was safe. Said it's better, and it's a lot better. And only thing I can comment on is the NFL. This is a case that everybody remembers, and this is Damar Hamlin. Damar Hamlin played defensive back for Buffalo Bills. Everybody was watching this game. He got hit flush like this. Let's see if I can go to the next slide. And Damar collapsed on that field. He went into cardiac arrest because he was the first case of commotio cordis, where his heart was hit, usually with baseball or a lacrosse ball, just at the time of the depolarization, or repolarization effect rather, that I show you below. Right? He's fine. He's playing again. And the reason is the infrastructure that pro football has put in place. Dr. Robinson would wish to have that down in his emergency department. On the field at Cincinnati were the head of the ED, the head of anesthesia to intubate him, the head of the ICU, and when I covered the Patriots for years, it was just that way. It was all full professors. Very unlikely to be any part of real reality these days. That's not a high school kid. I would argue it's not college either in most settings. That's the reason this young man is alive, is the depth and the significance of the protocols that have been put in place in the last decade. Okay, I want to recognize Christy Arbogast, who was kind enough to share with me some of these data. And the data talk about reporting and reducing concussions, which is where we'll spend about 3-4 minutes. And you can see in a timeline from 2015 to 2022, the remarkable increase in protocolization of diagnosis, somebody up in the booth looking at this, people doing biomechanics, video reviews, and they're still not perfect. But they're better. They're better. What did they do to the game itself? So many of you, like me, who are older, are completely confused by looking at the way that they do kickoffs now. Absolutely, it looks perturbed to my eyes. But here's the issue. There are only so many ways to mitigate the injuries, one of which is equipment change. We'll talk about that in a second. The other of which is to change force mitigation and practices. So the number of practices grossly reduced. Nobody is doing what some of us who were older grew up doing, which were Oklahoma drills, batting heads against each other. It was lovely in the state of Florida in August. But these change in rules have had a remarkable effect. Kickoffs were 7% of the plays, but 16% of the concussions. The remainder of the players start now between the 35 and 40-yard line, so they don't get a running force at each other. There's no running start. It's a 43% 3% reduction. That is huge. It doesn't make it safe, it makes it a lot better. Let's look at here. How do we diagnose some things? This is the old Case Keenum video. Dan Dinesh, Chris, and I had developed a series of early signs, some of which were the change in ataxia, some of which, if you'll watch the secondary part of the Keenum video here, he gets up, right? And in the second piece, there's Nick Foles, the person all New Englanders have a PTSD to, but you'll see the rerun here, and he grabs his head immediately and shakes it a little bit. The shake sign in football is over 90% linked to someone having had a clinical concussion. It's a newer sign. So we keep finding things that are additive to the portfolio of what we need to do. And people have rewritten those rules very expeditiously. You'll see any posturing, any wobbliness or ataxia, and what he was doing here. Okay, so how do we re-engineer things? And I hope this will play. It does. So Christy gave me this video, and this is a Chicago Bears player hitting directly on, right, a Dallas Cowboy player. Now, look at the spike there in resultant angular velocity. And angular velocity is going to be a key issue that we will talk about later in about 4 or 5 minutes about pathology. So that hit's been outlawed in the game. Not only for its rate of head injury, but for the worry about people's necks, because the axial load to the neck is insane. Number 2, let's look carefully. This is the rate of innovation. So people used to keep the same helmets all the time, only they were bad. What began in 2015 is a series of helmet testings at Penn, at Vatech, and a number of other places. And when you started reporting the results, guess what happened? The innovation, the biometrics of the helmets got better, and they correlated with the clinical outcomes. So what you see now is things much more like this. So this is a typical NFL locker room where you'll get, these are your choices in the bright green. You can only do the greens. And they subsequently begin to prohibit others. Those greens are linked with improved outcome, a lower likelihood of concussion, and a shorter duration being out. Innovation and reporting creates demand. Now, when we look here, let's see if this doesn't play, that's okay. We see a few things. We see innovation not only looking to be helpful for the list of things, but to say, is every occasion the same? If you've ever watched quarterbacks, and we just did with the Case Keenum video, how did he fall? He fell backwards. That's different than our friends in the offensive line who go this way. So we now have position-specific helmets, trying to diffuse the force in a better, more logical way where the risk is most likely to occur. That makes a bit of sense. What also makes sense is this testing of these Guardian caps. I thought it would be garbage. Honestly, I was wrong. So they first came out and looked like big old inflated mushrooms on people's heads. And they were slipping down on the guys and they were yell and throw stuff at people. And they were right, but they fixed it pretty quickly. The average impact reduction was over 20% when both players were landing this, and over a number of years. What you see, it started in 2022, but it's gone on now. People can optionalize, use them during professional games too. You see this kind of a drop during preseason. Preseason was a source of unneeded exposure that has now been downregulated. Are things safe? No, completely safe. Are they better? Yes, they are better. So we're going to now take this Gordian knot cause, and the dean has heard me say this too many times, but many years ago, centuries and centuries, Alexander the Great was in Fallujah in northern Turkey, and he was presented with the opportunity to untangle this knot, and he would win all of Asia. And he cut right through it, as for those who's read his history would want him to do. We're going to have a trouble being Alexander the Great today, but we're going to try to cut through some things. So I don't always love common media, not that they're bad folks, they have a different mission, but I want everyone to pay attention to this. This was a simple survey done by ESPN and the Kaiser Family Foundation for people who are older, former players over 55. Yeah, they've got some pain, disability, some people have memory issues, and very few of them say they wouldn't have played the game. Very few. In my patients, it's 1 out of 100 because it changed their lives in a lot of different ways, and they can't replace that high. Doesn't mean it's safe. Doesn't mean it's okay. It means people can make choices, and our job is to think about the health implications, how to mitigate that for youth and for others, and what lessons we can learn. Okay, let me move quickly. Age matters in almost everything, okay? I'm clearly on your left. I'm the crown prince of apoptosis. Many of you are on the right. But it is the greatest corrective factor you can ever find. And for us, we're less interested in people who are super old. And the reason is they got a lot of noise, as I'll show you. But I'm most interested in helping people. You shouldn't be that diseased at age 55, 60, 45. When you're 85, no offense to anybody, it's harder to tease apart. It really is mechanistically. And so human systems interact, and we're going to try to look at what produces a maladaptive phenotype. So this is from our book, and it was an idea that David Arsenegas, myself, John Silver, Nathan, and I had some time ago, which is to look at pre-injury factors, injury and exposure, post-injury factors that produce a myriad of concerns in people, and not understanding one part of it and just assuming it's all monotonic is a little bit of a challenge. Let's first look at neurodegenerative disease. So this is the number of publications regarding CTE or repetitive trauma-related neurodegenerative disease since 2005, right? So it's a relatively newer disease, but it's not. It's not. This figure is Harrison Martland, a Newark pathologist who described punch-drunk syndrome in 1928 in boxers. Their phenotype, however, was described as different. The pathology, which we'll only spend a marginal period of time on, was best described by Anne McKee, and there have been a series of NIH and INDS conferences around this where you see tau-related protein, phosphorylated tau in the depths of sulci and perivascular regions. And tau, for the many of us, really should be a stabilizing molecule. It is the bridges in a railroad, and then once it becomes phosphorylated, you get these tangled clumps, the microtubule subunits fall apart, and you get neurodegeneration, just to be a little cartoony with it. This is a paper by Falcon, he's a friend, and basically what you see is that in CTE, there is a novel tau-related, phosphorylated tau-related protein that is probably hydrophobic. It's hydrophobic. Now, does this make sense? So there are a series of these papers looking at computational modeling. And what you see is the tau tends to deposit, at least in its relationship to postmortem samples, in areas of the highest acceleratory strain. It makes sense. There have been those who basically said, well, all of this is a bunch of garbage, and everybody's got it or everybody's not got it. Probably not the case. So if you look at some of the largest series, and it's 37% in the exposed and about 1% in those who are not. So if you use what's called Bradford Hill criteria, strength of association, consistency, specificity, temporality, biological gradient, plausibility, etc., you come to the conclusion that there is a linkage and a probable causation. Okay, fair. Why doesn't this occur in nature? It does. These are bovids. They're rams, in essence, and they hit each other in the head for fun. And they actually exhibit, in similar strain areas, phosphorylated tail. Now, the question with this is sort of interesting. How could they do that and propagate the species? So either they don't live long enough to see the sequelae, they have a series of clearance processes to make it non-significant, or they have some other anti-inflammatory mechanism that doesn't let this go on to a Peyronie's-like spread. And we're looking at that. Now turn to people. So this is Jesse Mez's famous paper that was in the front of the New York Times. Jesse's a friend. 110 out of 111 NFLers have, who passed away, who died, sorry, have evidence of CTE on the pathologic. So these are people who are dead. They're not alive. We're done, right? 110 out of 111. Here's the problem. The problem is this pathology is very real. What we don't know is the linkage to the phenotype. So there are people who may have the pathology who may or may not have an abruptive phenotype. Just like there are people who likely have right coronary artery calcium but get bored running after 5 miles, like me with my attention deficit disorder. What happens here? So this is another paper by Jesse that showed the odds of, from a pathology study, non-living people, people already donated their brains. There's also a bias in that cohort because families believed they had it. Double every 2.6 years of football played. And this is one of my mentees, the terrific Dan Dineshvar. And what Dan did is he looked with us at force and said it wasn't related to just years of play, but really it's cumulative linear or rotational acceleration related to the stage of CTE that people had. These are all pathologic studies. There's another caveat in the pathology. Can you see things that look like this in aging? Yes, it does not explain CTE. And in fact, people who are not experts get confused with age-related tau astrogliopathy or PART that can occur with aging. Part of our driver reason, and what I will show you in a minute, as to why we focused in on studying people in middle life, not so much in ultra-late life. Okay, can you see in-season change in humans? Can humans demonstrate in-season change while they're alive? So 2 papers, one was ours, was Inga Korte and mine for some time ago, where we actually did kids who were in the Bundesliga in Germany. And what happens there is they pull kids out at a very early age, and they become like soccer school. And they spend a good half their time playing soccer. And what we were able to show is diffusion tensor white matter integrity change within the season in these kids. So not football, but this is football. This is the group at Penn State, Zablovnik, and they showed on fMRI default mode network change during in-season in players. Okay? The issue is, what happens after the season? Does it just go back to normal? Does it mean anything long term? Is it a proxy for anything? One of the key issues that I brought up a second ago was, what's the phenotype? I don't care really what I care, but what I really care is, are you sick or not? And so this is criteria that we all did for the NINDS, where we looked at traumatic encephalopathy syndrome. So let me split these for you. The pathology, CTE, the syndromic traumatic encephalopathy syndrome. At least 5 years of exposure, neurobehavior not accounted for by other diseases, not just depression especially. Comorbid diagnoses does not exclude TES, substantial exposure to head impacts, but cognitive and neurobehavioral impairment that's progressive and quantifiable, and it comes with probability scores. This is probably going to mostly hold up. Mostly. We may need to change it a bit. So is there a link to the pathology? Yes, sort of, kind of, and maybe. So this is a recent analysis from the group in Texas, actually. Not well described neuropsychologic testing, cognitive impairment, unclear. You see the forest plots are mostly in the middle, especially if you take out one study or two. It's not overwhelming. And indeed, even in some of the BU data, the links to the phenotype are unclear. So might I propose to you that maybe, as a hint, hint, there are other things that are needed with the pathology to produce the dark effects. Other sports. Well, you do see it in hockey, I'm sad to say, especially among enforcers, guys who are essentially fighters, right? They're usually bigger guys. They fought throughout the OHL or the Q, and that's what you see, a pretty strong linkage. And David Sharp's group in the United Kingdom, who are friends, have now shown biomarker evidence of neurodegeneration in midlife former rugby players. These were all professionals as well, and we're working a bit in the RESTORE study with Fiona Sanders, who runs a lot of work with Ireland Rugby. So let's look quickly at humans. Can we see now human links to the data set? This is an old study by Lehman et al. And what they did is they looked at players' mortality after 1960. So when the hard shell helmet came in, professional players, 1960, 2007. Look at the SMR, or standard mortality ratios. ALS 4, dementia 4, Parkinson's 1.5, and change. But this is noisy. They compared to Bobby the accountant. This is work by Danny McKay and Willie Stewart in the north of Scotland, my friends. And this is in the New England Journal, and what did they show? This is Scottish soccer players, not footballers. They're interested in cause of death. Look at the numbers. ALS, David would be interested, 4 and change. Alzheimer's 5, if that was the right diagnosis, and dementia 4. So 4 or 5 times the chances. Doesn't mean that everybody gets it, because the overall number is low. And this is Willie's group again in rugby, and you see a crazy ALS rate that we didn't lock in here, but that's related to the small numbers that he had in that group. And then Dan and I and others looked within the NFL at ALS mortalities, and so it sinks. It's a 4-fold change. So trauma, probably in the susceptible, may lead to enhanced neurodegenerative disease risk. But what enhances that in everybody? Maybe there are things we can combat, fight, or do something about. Let's think about it in just a second. I was asked by David to put in some high school data. I did quickly last night. So just listening and responding, we typically don't study high schoolers because of the variability of their exposure. But here's some data from Grant Iverson in our group. And what Grant did is basically he was not able to see post-mortem tau in basically adult men who participated in youth amateur American-style football. But other reports have. There have been cases of CTE, and exposure and vulnerability may matter. So this is a kind of a cool study. And this is one from Wisconsin, 1957. Even I wasn't around. Okay? Even me. They followed all these high schoolers in Wisconsin who played and compared them to a cohort who didn't. They're fine. They're completely fine. No behavioral issues, no depression. Is that the real story? Well, we don't know, because there's such huge difference in exposure, right? One kid might have played 2 games, sat on the bench. The other kid was there all the time. The reason the pros have extreme exposure, ask many of them, not all, but many of them, their story, and they will tell you, well, you know, I rarely got off the field. I played defense, I played offense, I played special teams. The reason is they're so good. The coach would have to be a madman not to let them keep playing. They have extraordinary exposure. So this shouldn't surprise us, really. It may not be the answer. I'm going to play this video given to me by the family of this young man, who I took care of for years and years and years. And he is playing here, and he's going to wind up on the ground. He is this guy, 16. No one is impressed by that hit who has watched a lot of football in their life. No one. Except he goes to the middle of the field and does that. Second impact syndrome. This is the thing to always be cautious of with high schoolers, right? They blush. They developed a subdural in many cases, at least by Alicia Geen and Bob Cantu's paper and a number of others, first described in the 80s, in which they developed this massive hyperemia and shift. It's the cause of some number of deaths per year, we think. Others are neck trauma, indirect cardiac causes, and the data is not gorgeous on this, okay? Doesn't happen in pros, or hasn't yet. It's probably people who are younger, who are vasomotorly less stable. Okay, so now in the next 15 minutes or so, I'm going to talk about the Football Players' Health Study, what we've done in all of that time. So our idea was to understand the benefits, which there are some, and risks of American-style football, and see if we could do things that were preventable, a lot of which was related to chronic pain, sleep disorder, neurocognitive, cardiometabolic, and musculoskeletal. So what we did is we actually asked the players, participatory action, what is bothering you the most? And we focused in on trying to develop links to that. The study has about 100 publications, a bit more nowadays, but many of which I want to show you over the next little bit. So we started to say, why are these guys dying? This is a paper by myself and Vu Nguyen, and what we did here is we said, man, general population is not a fair control group. Major League Baseball might be. They're athletes, they train. They don't exactly have the weightlifting and size, at least traditionally they didn't. And they don't take the head hits. And what you see here is there is a neurodegenerative disease effect comparing to baseball players of their all-cause mortality. But when does it occur for the NFL guys? It occurs late in life, in their 70s and 80s. They die early of heart disease. It's heart disease that kills them early in life. It's heart disease that robs them of early middle life. It is a repairable phenomena or avoidable phenomena. So we began to want to take a look at this. We have a longitudinal part of our study, an early aging program, an innovation section, and a collaborative initiatives. And I'll just show you very, very briefly some of these innovation studies that have been focused on osteoarthritis, something I hope you'll see a paper about in the near future related to a brain pathology, PNAG, a hydrogel, and a number of other things. So those who do orthopedics may know Martha Murray. Martha Murray actually developed a scaffold for direct repair of ACL tears, not via transfer, and that is actually going on to a company to be able to translate to real humans. So is Nitin Joshi's work, where he developed the hydrogel in which it really only expresses the anti-inflammatory agent when they're in an inflamed joint. And when they're not, it sort of self-collapses again. And we also noted, as I'll show you, a very high hypertensive rate and have developed an algorithm and a way for these guys to actually early on have a blood pressure remote controlled algorithm that allows them to be treated early on. A lot of people have chronic pain. And so with our colleagues at Morehouse, we've been developing a remote intervention for chronic pain that is likely to become patented fairly shortly. So let me talk a little bit now about how we viewed things. We viewed things as the whole player, the whole life. So it's not just your head. You have musculoskeletal issues, it affects your sleep, it affects your heart, it affects your men's health issues, and brain and body. And then we see all of these issues. So we brought a large number of gentlemen into Boston. Remember, our study now, and I should have told you that before, has 5,000 guys, 5,000 former NFLers. And what did a lot of people go through? Sleep studies, brain and behavior, brain and liver MRI, PET CTs, cardiac studies, which I'll show you some data, olfactory studies, how do they smell? And can we use that as a marker for an intervention? And EEGs. And we recruited them to make sure that we had a diverse group of persons, that we weren't just boxing for people living in New England. Okay, so we have a lot of interactions to talk about in the next few minutes, one of which is false beliefs. So I'm going to address one of them. If you start early, you're going to wind up with more problems. No. That was based on very, very small studies. Our study of over 4,000 guys showed that that's not the case. However, I wouldn't do it. Right? Kids are younger. The few that will go on will have more exposures. No one who's that good needs to learn to tackle before they're 14, 13, 15. There are major caveats with that, including the fact that the size mismatches in those kids are tremendous. Some of them are like, Laura's looking at me, they're sort of like bobbleheads, right? And one thing that I noted when my son was playing hockey and in other parts, people who know what they're doing can teach the kids correctly. A lot of the youth-related coaches have all respect to everybody, no idea what they're doing. You bring a professional player, either hockey or football, onto that, and they're like, their eyes are this big because they're being taught wrong a significant portion of the time. That's why I'm not enthusiastic about the kids hyper starting early. We have noticed a number of things, and I just cartooned this for brevity purposes, but what we have seen is, and I'll show some very small data about this, an enhanced rate of oxidative stress, especially in the big guys. So if you look at this work by Megan Wasfi in our group, what Megan has looked at is BMI by oxidative stress. And what you see is that when these guys play a game, the bigger they are, the larger the amount of inflammation. And then what we see is that this work with Charles Serhan, Charles has worked for years on specialized pro-resolving mediators, SPMs. SPMs are a critical part of our active resolution of inflammation. I would suggest they are an underappreciated element of chronic disease, alterations in SPMs. When you take a look, please do not copy this part of the slide. It is not yet published, is that you see huge outliers at the top in SPMs and inflammatory related response, and those are tied to maladaptive phenotypes. Genetics. Repetitive head trauma and ApoE4 induce chronic cerebrovascular alterations that impair tau elimination. ApoE4, if you're 4-4, you have a 12-fold or so risk of Alzheimer's. If you are a 3-4, you have a 3 to 4 times risk of Alzheimer's. Interesting paper the other day that suggested you can change that a bit with Mediterranean diet. You can forestall that. Let's look at who people are really quickly. So many of you remember McEwen's idea of allostatic load. Early life stress results in fight or flight. You get this cortisolic response, and you change your brain morphology from early life exposures. This is a paper we did in JAMA Open. The number of ACEs is on your y-axis, adverse childhood experience. The risk ratio of the poor outcome is on your x-axis, and what do you see? The more adverse childhood experience, the worse these people wind up in the end. This, however, is pulled out for self-declared race and socioeconomic background. So it's all about a lot of these adverse childhood experiences that we never even ask about for people. And those stressors change our responsiveness. This is Amr Dahan's paper, and what Amr did is he looked at social networks with Laszlo Barabazi. You know, how close you are to others. And those things are critically important when we think about social health behaviors. If I want to lose weight, I hang around with people who don't eat fries. If I don't want to lose weight, the exact opposite. Does this a one-to-one? No. But isolation is, as we all know, a critical element of people not doing well. No question about that. And what we find is when people have been in either the military or in this kind of situation, and they leave suddenly, and very few people leave because of choice, right? That's hard. That's a burden on people, and a real one. The more disconnected they are from others and their normal cohort, the less resilient they often are. In fact, we're now using this network analysis to predict who needs what kind of service. So I'm a big believer that nocebo effects are big. Nocebo is the opposite of placebo. If I tell you you're going to do poorly, you're at risk for something, people who may have a genetic predisposition will likely do badly. It doesn't explain everything. But the more negativity people hear, the more they adopt. It's a very well-known fact, right? In the US, we have much higher nocebo rates than in Europe for clinical trials, and the answer is simple. We advertise it on the television. You could get this, and this. And it has a real biologic mechanism. So telling people only the negative instead of telling them about risk and how to mitigate risk may not be good. Next thing I want to bring up is control groups. Who are the control groups for these gentlemen? That's who we're going to have to compare to make a conclusion. It's not so easy. The community? I doubt it. Social groups? Maybe. Brothers? That's what we're using. People's brothers who didn't play. It's hard to find, but you control for socioeconomic status and genetics. It's probably the best comparative group. The other assumptive is the longer you play, the worse you are. No. So here what we see is various models that basically show those with the shortest and longest careers were relatively less exposed to disease than the people in the middle. Why? May have been playing style. It may be that they learned to play with their hands, that they're survivalistic, that they were unique in some ways. If you talk to a bunch of guys who were my friends on the Bills, many of them were wrestlers, right? And they were very good at keeping people off of them immediately. It's a hypothesis. I don't know if that's true or not. Some people have claimed that you can find CTE, the pathology, in living players. Turns out this paper in the New England Journal seemed to indicate that with a pet study. But we replicated that and found not only couldn't you do it, not only did it not have a meaning to neurocognitive outcomes, but T807 doesn't work at all because it binds melanin for people of certain ethnic backgrounds. It's essentially not so good for that group of people and causes bias in the data. Catecholamine dysregulation and various chemokines have been suggested as a driver in the living for potential challenges in this population. So now let's look really quickly at a few things. Percentage of people who believe they have CTE and have comorbid diagnoses, depression, obesity, pain, hypertension, sleep apnea, high cholesterol, low testosterone, all of which are compatible. So yeah, they may well have the pathology, but you might be able to make people feel a lot better also by treating what you can treat. This is some work, please don't show this slide yet, by Grant Iverson and our group. Brain age is a bit smaller, but it's also linked to early life hypertension, exercise, sleep apnea, and about the amount you've been exposed. Compatible things exist. Neurocognition, we've been able to show that when you ask people to do two things at once, you might be able to pick up some early signs. So neurocognition is sort of dual task is I ask you to walk a tightrope and then count backwards by sevens, right? So-called dual task. Those with the worst outcomes have the worst scores, right? It's a distraction effect. Suicide. So this is a very complicated episode. TV wants to link suicide to pathology in people, and simply that's not the case. It's super complicated. There are many reasons, and all of them unfortunate, why some people commit suicide. Some data from 1960 to the middle 2000s actually showed a lower death rate than other men. But there's no clear data that is for sure linking suicide. But I think it's a complicated story. There is a data point that says head injury, depression, risk. So it's a knotted story again. Let me go on to this one really quickly. And that is this idea that many of our friends have heart problems. And here's the reason why. This is Aaron Bagish at the top. Aaron is the guy who did the Boston Marathon for years. He's done a lot of work in athletes' hearts. He's one of the preliminary people in the world. And what we were able to show is, and Aaron's work has shown, is that the heavy lifting that people do is very valuable, except if you're not doing concomitant a lot of aerobics, it produces a concentric cardiomyopathy, hypertrophic cardiomyopathy. Those people have a higher chance of hypertension. This is a funny story that you see years ago when I was in a different environment. This is someone very famous trying to do a squat, unbelievable amount of weight on a squat. And he was kind of a card and asked, can you spot me, doc? I said, no. I can't help you at all. And this age of hypertension is associated all the way back to the UK Bang Bang with brain structure and dementia. Hypertension is something we can detect in players now and treat. This is our data from the Football Players' Health Study. Look at the hypertension rate in dark blue. It's crazy. And we believe it's related to both inflammation concussion, and autonomic dysfunction. Let me ring here for a second. These are VO2 max. This one isn't to be shown yet either, although it will be shortly. Our guys have altered cardiac output. Their cardiac output should be better than everybody else's. Well, up with that. They certainly should be better than the local accountant. So again, a knotted story. And that here, concussion history predicts later life cardiovascular dysfunction. So do we have an autonomic and inflammatory relationship to heart disease? And is the way people train the opposite part of that circle? So here we have, that's Marty Samuelis, who the dean will recognize in the corner, the late great neurologist, who really turned us on to this idea that heart disease and brain disease should be, or could well be, interrelated, and was an important thing to consider. Many of these things have more to do with other risk factors than older age or race or body mass index. It's not just that. So we did this paper in the Lancet Neurology that talked about this, and it looks like there is a strong linkage of this throughout the relationships with brain injury, and we should be screening these folks. If you meet the physical activity standards, we did a close observation of these guys, they don't have problems. Now that could be self-fulfilling, they don't have joint pain either. But they don't seem to have the same sorts of problems: dementia, pain, sleep apnea. So in transitioning people, should we think about that as a critical element? Let's look at metabolic. So many of you remember force equals mass times acceleration, right? Gene Upshaw founded the NFLPA, super great guard, right? Brilliant man, passed away. He was 6'5", 255. For those who follow the game, Josh Allen is a quarterback. He's 6'5", 240. The game has changed, right? Look at this. This was from my old alma mater. I wasn't there in 80, but not that far after. The guys on the offensive line were 245. 245. 245. They wouldn't let them in the room now. They're 330. They added me onto there. And so we looked at this issue, weight gain. If you gain weight early in life, or from college to the pros, if you gain this massive weight, and those who've played can tell you that a lot of people have to wake up and take shakes and take on a lot of calories, that's linked to disease. That's chronic inflammation. So among the things we tell people, we're not going to make them thinner for the game, but once they're out, lose weight, tone up, get thinner. Endocrine issues exist. So the number of loss of consciousness are linked to low testosterone level and erectile dysfunction in these gentlemen. And it makes sense. It makes sense. They have brain torsion, right? Loss of consciousness being more likely that kind of a torsional activity. Lastly, I want to get into this issue of pain. Pain is a biopsychosocial issue, but remarkably underappreciated, right? Arthritis is a huge issue in this population, underappreciated one. It has a penetrance that's off the wall. And pain tolerance is something, I just want to do this, that is underappreciated. So we put these gentlemen's hands in ice water. It's the old pain tolerance test. And I assure you, that water is cold enough that most all of you will go like that. They're in there. They're selected for better pain tolerance, right? They can handle things that others can't. That doesn't mean they don't get hurt. That means they have abilities to tolerate that are remarkable. But that ability may come with a problem. So this is Marco Logia's work on TSPO and PAT, but what you can see is that chronic pain results in brain inflammation. Let me now show you one really quickly that is unexpected. A lot of people have ACL tears. those ACL tears are linked to a lot of things, including myocardial infarction. A 52% increased chance of having a coronary. Why? NSAIDs? Maybe, but we looked at that. It's probably chronic pain and immobility. Chronic pain is an inflammatory. These gentlemen really do have absurd rates of chronic pain. I want to bring this one up. Sleep apnea. The rate is debatable. 65, 70% of the guys have sleep apnea. Wide necks. You can't play pro football with a size 15 neck, right? That's actually a remarkable advantage, except puts you at risk for sleep apnea and a number of other things. But please don't, on this slide also, because it's almost out but not out yet, sleep apnea, look at the linkage between diagnosed and untreated sleep apnea and anxiety, depression, cognitive symptoms, and pain. It's off the wall. We've been able to show olfactory signal. So using different odors with Mark Albers, who I'm sure the dean knows, that some people who have very maladaptive phenotypes, they're not doing well, have odor discrimination issues, and that relates to certain brain volume issues, right? Well, possible. Diet. So diet is a big issue. Dietary salt promotes cognitive impairment through phosphorylation. Where do many of our folks come from? My home state of Florida and a number of others where salt is a big issue. And we showed this with SAFE, Izzy, regarding salt and anxiety. So here's some papers that we did where we used a mouse model and recreated a high salt diet after repetitive trauma, and then subsequently looked at the phenotype, and what we were able to produce is microbial dysbiosis and, honestly, a severe anxiety phenotype. So these are all repairable things. So how do we make sense of all of this? So these are extraordinary gentlemen with gifts that are unbelievable, dedication that is remarkable, in which I would argue some of their normal aging is shifted to the left. This is a paper that Rachel and I did, Rachel Gasha, by various risk factors: obesity, pain. Many have experienced racism, sleep apnea, multiple head injuries, hypertension, depression, and cardiovascular risk. And so on the other side of that slide, what you see is we compared them to a number of other individuals, and they lose about a decade of health span. A decade of health span, of living without the burden of disease. So they're older quicker in some ways. We've been able to measure this with a couple of different things: epigenetic clock biomarkers, where we've seen some early demethylation in people who have a maladaptive phenotype. And not to bring up my old colleague Fabrizia Ambrosia, but we've been working with Fabrizia using Clotho as a candidate biomarker for early aging in this group of people. So lastly, I'll say health span versus lifespan versus joy span. Health span is how long we live. Lifespan is how long we live. Health span is how long we live without the burden of disease. And joy span is, are we doing and able to do what we really enjoy in life? So I do care about prolonging people's lives, but I care more about, can they do what they want as long as they want to do it? Lastly, we've been doing these McCain brain care scores. This is John Rosen and Singh's work to kind of identify those who are at risk and put them in some of these Mediterranean diet, lifestyle, blood pressure control things, while we're trying to attack various proteins and other things that are clearly abnormal, and use those for others. So quick conclusion: biopsychosocial health covariates count. There is a complicated maladaptive phenotype. Not everyone is sick. Repeated brain injury cannot be good. The directionality may go multiple different ways. There are a lot of things we can treat with people and make them better or prevent problems. Medicine is the most, this is my dear friend and colleague Herman Taylor, medicine is the most human of sciences and the most scientific of the humanities. We should remain curious and humble. Thank you, gang. Sorry I went over.
I understand we're already past the top of the hour. I know some people will probably have to leave, but we're going to take a couple questions before we wrap up. Before we take those questions, Dr. Zafonte, I really want to thank you for your work and for sharing your work, and
Thank you
give
so
you
much.
this token of our appreciation.
Thank you, Brian. Much appreciated.
So if you have a question, just raise your hand. We'll run the mic to you.
Can CTE be reversed?
No, in fact, it can't be diagnosed in life. So one of the things I probably should have done was just tell you that CTE cannot be diagnosed in living people at this time. And I don't believe it can yet be reversed because we can't diagnose it well in living humans. Now, future things, there are people working on cis-tau antibodies. There are people who are looking at potential secondary infectious phenomena that are causing some elements of CT in this spread. But right now, I would say that's years away.
I guess a more general question is, can TBI be treated?
TBI can be treated. TBI can be treated. But again, I want to separate for us a little bit the pathology, which I'm super interested in, and the phenotype. They're both important together. One represents a risk for the other, but there are a lot of things that I think ignite this status that we can dampen down now. If you take a cohort of people who have Alzheimer's, who have A beta, and it's not everybody gets sick. It's the people often in some of the cohorts who have large inflammatory processes who probably push themselves along at least earlier in life.
I did have a question from the audience. Can you talk a little more on men versus women in regards to TBIs?
Sure, we can. It's not related to football players' health study, obviously. So there's lots of data, some out of Michigan State, some out of a number of other places, that talk about risk factors for females versus males. There is a higher incident in equal sports in women. There is a suspicion, some of that is related to neck mass. Some of that is related to the way certain sports are played. If you look at analytics, women tend to play a little bit with their elbows higher. If that's true or not, I don't know. And they tell the truth.
So with that, we'll wrap it up. Please join us next month in Rolla or online if you can. And also, there's 3 more weeks for the Next Gen Precision Health Next Gen Fellow program. So please submit your applications. And let's thank Dr. Zafonte one more time.
Sorry about going over.